Well, thank you, Brent, and it's really a great pleasure to be here, a real honor to have an opportunity to speak to you. I come with a number of different perspectives about all this. Of course, one perspective is that of an African-American physician. Another perspective is I sit on what is essentially the State Board of Health in Texas, and we're responsible for the regulatory function of the state with regard to hospitals. I come to you with a perspective of having served 2 years as chair of the National Association of Public Hospitals, which we now call America's Essential Hospitals. And I'll be talking about that public hospital involvement in particular. And I come to you as a CEO of a small rural hospital with very narrow margins, but really critical to the safety net of Northeast Texas. I have the belief that a couple of things. One is that it's all about culture. Culture is critical to this whole issue of patient safety. And wow, things have really changed. When I think back when I graduated from medical school in 1978, quality was making sure that you were not yelled at by the attending physician for not doing things the way they wanted things done the night before. And as I progressed as a physician administrator, I remember the quality assurance days. It's interesting to note that we always felt we had quality. We were assuring that was present. And the way we did that was we created reams and reams and reams of yellow paper, because the yellow paper never left the room and could be shredded after our monthly meetings of making sure that we were fulfilling the minimum requirements to get through a joint commission visit. That was the thrust of what quality, I think, was for many of us. And there was an assumption that we were doing very good things. In fact, that assumption, if I can get this right, that assumption, particularly for those of us who were working in the public sector, was that we were doing God's work. And of course, there was no possibility that we were somehow harming patients. If you look at public hospitals around the country, if you look at America's Essential Hospitals, there are 250 hospitals who are committed to caring for vulnerable populations. A lot of very special services are provided: trauma, burn care, NICU, so forth. We have really expanded, because of a great need in Texas, psychiatric services out of our hospital. Not very profitable, but critical to the needs of the patients in our community. We are involved in training a great many of physicians, nurses, other healthcare professionals in these public hospitals. And so, to the extent that we were successful at providing services to these vulnerable populations, to educating that next generation of physicians, we were pretty happy with ourselves. We were enthusiastic to pat ourselves on the back. And it was difficult when, to err is human, and crossing the quality chiasm. When those reports came out, I must say there was a bit of disbelief that somehow there were deaths, 100,000 or more deaths, attributable to the types of care that we would do. By the way, look, we had all these reams of yellow paper. We were doing good things. Of course, when an error would occur, it would maybe be overlooked, or it was just bad luck, or it went into the pit of peer review, never to be heard of again. But that all changed, and has changed tremendously, I think, for all of us. Again, a particular need of an issue for public hospitals is the fact that we serve a diverse patient population. that there are a great many more minorities who access public hospitals, and therefore the quality of care rendered in our public hospitals becomes a health disparities issue. Because to any degree that the quality of care that we render in our public hospitals is any less than the quality of care at private hospitals or hospitals that may enjoy a larger margin, then that is a serious problem. It is a public problem that needs to be addressed. So right now, there's great recognition, I think, on the part of public hospitals on the important role we need to play in improving quality and reducing hospital errors. I think that there is an admission now that errors do occur. In fact, an expectation now that we have errors. That was said in one of the previous addresses, and I think that's very important. When I first came to my institution, I was making rounds through the hospital. I was going on a TB ward because we were the old state's tuberculosis sanitarium. And I noticed a door was broken. And I asked the nurse, you know, how long has this door been broken? And she said, for years. And I said, well, why didn't you report it to someone? And the response was, well, no one would ever do anything about it anyway, so we just chose not to report it. That was a broken door. That kind of approach had actually spread into many other areas. And there's no way you can manage an organization if your people do not feel comfortable coming forward and reporting. And I think for public hospitals, one of the most important changes that has occurred is that, as Brent was saying, this need now, this encouragement that people come forward when there are adverse events and they make us aware of them. In fact, we monitor now, and at many of our public hospitals, we monitor the actual reporting itself. And if we identify areas that are not reporting, then those areas need to be looked at very, very closely. We had our hospital engagement network that was run through America's Essential Hospitals. We've now blended it with the VHA HIN network. And there were 3 areas of focus. Of course, we wanted to reduce harm, whether there were bloodstream infections or urinary tract infections or surgical events, medication events, and so forth. We outlined a number, falls and so forth, and we began to monitor those very closely, put a great emphasis on those. We put an emphasis on engaging families and patients in the network, realizing that there are some particular challenges that exist there because you're dealing with a poor, more challenged population. And again, along those lines, ensuring that there was racial and ethnic attention paid to making sure that any disparities that existed were properly addressed. And so a big effort was put in place to make sure that we would collect that kind of data. So how can we create a culture of safety? You have to, when you're CEO, you have to sit down with your chief financial officer and make a valid argument for just about everything you're going to do because the margins are so thin. Now, I've never had a CFO who has said, I want to see a patient harmed. But they will challenge you on where you make strategic investments. And is there return on investment? And the return on investment that I like to point out is that these efforts, first and foremost, do improve patient safety and avoid patients being harmed. Equally, they help protect the reputation of the institution, which is important to public hospitals, which enjoy public support, and by the way, would like to see a private patient every once in a while. So reputation is extremely important. And I think we've been able to demonstrate that there is a financial benefit a financial benefit to the system, directly and indirectly, in reducing patient errors, and by earning quality-based incentives, but I agree, I think those are minimal drivers. Through the public hospital HIN, we have prevented more than 4,000 harmful events to patients with a savings of about $40 million. I believe nationwide, from reports from the HIN networks, that those savings are well over $1 billion nationwide. And so there is a very tangible benefit for the CFO to see as they consider these things. I will end by just saying this. We had an adverse event in my hospital last year. I can imagine how that would have been handled several years ago. This time it was very different. It was reported, it was brought to the attention of the leadership team, it was brought to my attention. My response was, I wanted to see the fishbone. My God, I'm using a term in quality. I wanted to see the fishbone of the event because I wanted to see how everything tied together. The quality team came to me and said, it's not just a fish, it's a flounder. The bones were going everywhere. But we needed to have that. We needed to have it reported. We needed to see where the systems had broken down, and then we needed to address those systems so that that nurse on the floor will never say that, no, I didn't report this, because they wouldn't do anything about it. We responded promptly and aggressively and in a non-punitive manner, and I believe our institution is the better for it. Thank you.